All right, welcome everyone. My name is Andrew Wister, Director of the Gerontology Research Center. Very terrific conference today for those who attended. I know it's a public lecture. Some of you have just come to hear Dan tonight, which is your lucky night. I have the pleasure and delight of introducing Dan Levitt. Dan is a close friend and colleague for many, many years, and I'd like to say a few things about him. Dan is an acclaimed international speaker, an elder care leader, writer, gerontologist. He specializes in helping older adults to create better lives and to celebrate those lives in a number of ways. Dan is the second BC Seniors Advocate, and first BC Seniors Advocate is here today, Isabel Mackenzie. I'd like to. Well, Isabel told me that she's sort of keeping an eye on Dan, so I won't put any pressure on him. And I'd just like to also mention that prior to this role, Dan was the executive director of the executive officer, of Kin Village, a number of other positions in terms of long-term care, and needless to say, he's been at the Gerontology Research Center and Department for a number of years. He's taught a course on administration of services administration of services and long-term care, and been extraordinarily successful course that students love because of its applied nature. So without further ado, I'm going to introduce to you Dan Levitt.
Thank you, Andrew. And Andrew was asking Andrew how long he's been doing this for, and I think 30 plus years. And
yes.
Barbara, how many years for you? 25. And Gloria, you started this 42 years ago?
42 years.
So people have said to me, hi, Dan, you have big shoes to fill. And I'm really glad that I'm filling Isabel's shoes and not Gloria's shoes. Gloria wears stilettos, and I'm being totally transparent. I've never tried stilettos. No intention to. So anyway, very honored to be here. The first, and I'm hoping to be interactive. So please, if it comes to mind, either shout it out, put your hand up, ask a question, and we'll try to have time for Q&A and some discussion later on. So the picture there, no accident. 1976, two researchers, Ellen Langer and Judith Roden, went into a nursing home in upstate New York, in New England. And on one floor of this care home, they gave all of the residents a plant. And they said to the residents, many of you know this research study, they said, you are responsible for this plant. You must make sure it gets sunlight, that it's watered, that it's fertilized, and that it flourishes. That was the experimental group. Then they went to the floor above that group of people, assuming these are homogeneous sample sizes, and they went to that group and they gave them a doll. And they said, this doll is a present for you. If it goes missing, we'll replace it. Don't worry about it. If it gets dirty, it's okay, but here's your doll. They left, the researchers, and these two social psychologists came back weeks later, and they looked at comorbidities. They looked at how the residents were doing. The ones in the control group hadn't done so well. They had the usual kind of decline that you might expect from people of that age and their condition, you might expect. As you would see in probably most people in care homes, there's a gradual, sometimes it's a stepped decline, but it's a gradual decline. And as you would expect, those of you who know the study know what happened for the experimental group, they did better. On all those indicators, they had less pressure sores, less falls, they had maintained their weights, some had even gained weights. So the message here was that the biggest difference was that they had a responsibility. They were called the responsibility induced group. And because of that, they actually did better. So this idea that you could go into a care home or work with a group of seniors and actually make a difference. That's what motivated me when I heard that story in psychology of aging at the other university in Point Grey. And I won't say the name. And it was a very big motivator to think that you could go enter gerontology like all of you have and make a difference. So that's sort of my story of what kind of wanted me to see a difference and why that kind of, if you think of it, disrupting the way things are is perhaps a good way forward. So Isabel knows these slides very well. If I screw this up, Isabel, I know you'll help me out here.
You'll do fine.
Okay, that's what she said in the first interview. So the number of seniors right now in BC is over 1 million seniors, 1.1 million seniors. So it means, and we have 5 million people living in a province, so it means 1 in 5 people in British Columbia are seniors. Interesting to note that when you look at where they are living, the majority of the seniors are living either in interior health. You think of the health regions. So everything basically from Boston Bar all the way to Cranbrook in the far southeast corner. So the interior really has many more seniors, and as you might expect, in Vancouver Coast, in Island Health, it's also about 26%. And if you go to certain parts of Vancouver Island, it's much higher than that. People tell you 60% and higher. So you think of, there's not an equal distribution of seniors. The other thing to think about is that when you look at our province, 20% of our population, so over 1 million people live in what's called rural BC. So their challenges are much more severe. And one of the last reports that Isabel released was around rural health challenges affecting seniors. You probably are familiar with it. So a little snapshot about seniors. So 95% of seniors live independently. So majority of seniors living on their own and doing fairly well. When that changes at 85, something happens at 85 generally, is that we see that more and more people are requiring care, more and more people are providing care to that person. The other third or so of the population never experiences that at all. And they end up dying without ever providing care to somebody or needing care themselves. 22% people at 85 or older are living in assisted living or long-term care. I can't remember the exact number, but it's something like another 18%. I'll close the door. Another 18% or so, but 40% or so of all the people are requiring care of some kind. So the other kind would be home care or home support. 80% are homeowners, and that means that they are all potentially eligible for the homeowner's idea that you can defer your property taxes. So we've been encouraging that and encouraging the expansion of that program. We think it's a good way of addressing the affordability crisis. And that means 1 in 5 are renters. And then you think about the hardships of renting, rent evictions are real. You probably all know about that. And of course, you know about the SAFER program that the office has been advocating for. We want to see more improvements on that. 14% are employed. That's good news and bad news. The good news is that we no longer have mandatory retirement, which I know Gloria experienced. It still seems an oxymoron that the gerontology department, the person who created it, had forced retirement, but I know you continued working, so we applaud you for continuing there. So, but the concern also would be people are working because of affordability. That would be a concern. So one hand, age discrimination maybe is less, but the other hand, affordability. Then 41% are volunteers, and touring the province for about a month in April, the one thing I found out and realized quickly is that the whole system is held up by volunteers. Without volunteers, I think this whole system collapses. So it's so critical. Again, I often wonder at what point do we not value a senior's contributions enough that we're not paying them? So something to think about also is that where you get your self-worth from and do we really value the contributions volunteers make? 8% have a driver's license, which are good. We're advocating that people who are driving have to get those medical exams, that there's an MSP billing code for it. And I was talking to the head of the Canadian Medical Association recently, who's from British Columbia. And that's one of the things we want to see is that when you go to your doctor, when you're forced to go to your doctor for this examination, 85 plus, we want to see that being covered. We think that obviously, if you don't have your driver's license, how that impacts you in terms of isolation, social exclusion, and now reliance on a public transportation system that you might not be used to. And then 5% are diagnosed with dementia. So again, there is a misconception, I think, in the general public that if you live long enough, you will get dementia or Alzheimer's, or that you'll end up kind of, with this horrible state of being that you would no longer want to live. And it's only 5%, but it's significant for those who are faced with that. So the future of aging in 12 years from now, not very long from now, 1 in 4, so 25% of British Columbians will be over 65. So you start doing some math. If you look at the number, for example, of long-term care beds, we have a general number with CIHI, the Canadian Institute of Health Information, that we should have 30 beds for every 1,000 seniors. So if you do the math, you can see we would be around 16,000 beds short currently, just in the next 12 years. So we have, and the first baby boomers, 12 years will be 90, and that the oldest baby boomers are 78. So we have some time, we have about 7 or 8 years before they hit 85. So we do have time. The ship hasn't left yet, but it's about to leave. So we have a short window of time now to make a difference there. Oops. So challenges ahead. Public healthcare system, there's a big pressure, obviously, just generally, it won't get any better with that population, but we don't want to also, this is where ageism comes in, is thinking about younger people, if you will, looking at older people negatively because of the amount of healthcare resources they use. So, and they're not contributing to society anymore. We forget that how much they already contributed, and we devalue them and devalue what they take, if you will. So there's that piece. So I would suggest, I certainly would suggest this before, I even suggest this more now, that we should be valuing them. So for example, things like vaccinations. Should the shingles vaccine be covered? We think so. Pneumococcal vaccinations, I call it the high octane influenza vaccine, and there's others that should be made available for seniors to be covered. We also look at things like hips and knees and other things that seniors are relying on from the healthcare system. Andrew Picard did a great article a few days ago about the devastating impact of a broken hip, and that often leads to premature death. So you think about access to healthcare, what that looks like. There's other aspects of this, ALCs, alternate levels of care. What's the role of the acute care system for seniors? Long-term care wait list. One of the 5 principles of the Canada Health Act is accessibility, which really means wait lists. So when you think about that, it's really a demand and supply issue. We haven't built enough in BC for sure to look at the challenges of this population coming down the road, the opportunities. If you were to, how we've dealt with it, I think my impression is that we've just tightened the criteria to move in. So it's harder to get to be eligible today for a long-term care bed, which is bad news if you're relying on the public system. If you're able to afford a private facility, there's lots of them there, but they're filling up very fast. In fact, they have waiting lists. There's a brand new one being built on the North Shore, and I think they have 120 or so spaces. They're half full, and they haven't even opened yet. And people are paying lots of money. There's that kind of that middle piece we got to think about. Where do they go? So we need to look at this waitlist issue and think about how do we solve this. The care homes that have been announced, I think the government's putting $3 billion of money into long-term care, mostly to get rid of those 4-bed wards that we saw that made all the news during the pandemic. They're mostly being built next to hospitals. And from my point of view, what I'm gonna just assume, I need to get more information about this, but I'm assuming they're gonna be hospital-like. Being next to the hospital, being run by the health authorities. But they will have a day program there, both for adults and children, that's good. And they'll be nearby the hospital, which is good when you need to access those services. So, but they're being built for about $1 million a bed. $3 billion is getting us something like 3,000 beds. I'm rounding up, and most of those beds are replacement versus new. So when you think about catching up with the numbers we need, Ontario is building 60,000 new beds. So there's a new construction. So 30,000 of those are new, 30,000 are replacement. So our numbers were 1/3 of the population of Ontario. They have 15 million, we have 5 million. If we use the same numbers, we should be at 20,000. So I just said we were building around 3,000. Okay, so we're falling drastically short. Living independently, we need to bolster up the support for people at home. And if you think about that person who's eligible for care home or assisted living, how do you bring those services into your home? So it might be wearables, it could be sensors you have in your home, it could be somebody monitoring you, not necessarily even from Vancouver, could be somewhere remote, but there'd be somebody who could come help you if you need help immediately. Could be a nurse, or could be a care aide of some kind. And you could also have things like automated medication reminders. That could all be in your home and also supplemented with home care. You could also have respite care supplemented. So especially if you're living with your spouse, and then you'd be able to go to this respite for maybe a week at a time. Or so to give your spouse or partner a break. If your daughter is the one who's caring for you. And we also look at things like adult day programs, which is one of those unsung heroes in the healthcare system, especially for older people. I had a chance to go visit Paul's Place today. And what a gem of that place. I know, Isabel, you're a big fan of Paul's Place. If you don't know about Paul's Place, it is basically a daycare for early onset dementia. And when we were leaving there, they were dancing. They order in food from, I think, the local restaurant downstairs, and they're having a great time. And it is privately owned. It's supplemented by, I think, the owners, although they wouldn't tell me exactly how they supplemented. The people who go there pay a modest amount of money. I think it's 3 days a week. It's a beautiful program, and they rent out a space probably the size of this room in the Hampton Hotel. So if you know about this place, it's brilliant. So we need to see more adult day programs. So I think that's kind of the third bullet there. And then insufficient appropriate housing. So we'll talk about that. If you were to look at needing to move out of your house where you live and find housing, there's not a lot of it available. It's just not there. You think about NORCs, National Recurring Retirement Communities, you can think about Abbeyfield, think about those different models that are out there, and even just apartments that would feel welcoming for seniors. We need more of that stock, if you will, out there. And then the affordable housing, we're building some. It's great to see the big federal announcement. I think that's a great thing that's happening, but I think we need more and more of that. And the challenge when you look at rural BC, for example, if there isn't a nonprofit or a municipal leader that cares about that kind of housing, it doesn't get built. So you have to find those places, and I think something I think the province, we could do a better job helping out those communities where housing's not being built. And then the last thing is probably our number one issue that we hear about is affordability and income challenges. So if you think about the income people have, 1 in 4 are on OAS and CPP alone, and they're really living below the poverty line. I think it's about $2,100 a month. I think we've heard that in our conference today. And you think about the rent that they're paying. So we saw this last presentation, I think $500 or so is the lowest possible rent you might expect to have. But imagine if you had to leave for some reason, if you get rent evicted, finding a new place would be catastrophic, especially if you're going to be paying market rent. So it's just not possible. So that's a huge issue. The other, I think about 50% of seniors in BC are living below income that would be equivalent to somebody working full-time on minimum wage. That's the plight of seniors. So Andrew wanted me to talk a little bit about ageism. So a few things about ageism. If you think about ageism, it is one of those last isms. There still are other isms, but if you think about if I discriminated against somebody based on their gender, we call that Sexism. Okay, do you discriminate someone based on the color of their skin or where they're from? Racism. If you discriminate against someone based on their sexual orientation, you might call it homophobia. Homophobia, what isms? Or so you're trying to find it isn't, right? That would be an unfair question on a final exam. Okay. But if you discriminate against an old person, you might call it ageism. Some people think of it as situational comedy. So and if you don't believe, if you think just spend a moment when you go to that store that was closed last week because of a cyber attack. Go to that store or any other store that sells cards, greeting cards, and just wait, don't go to the humor section right away. Go to the section, just go look at the birthday cards for 16-year-olds. Okay, and then go look, or even 21-year-olds. They're all happy, you know, you're about to do something, you're entering a great phase of your life, and then go look at the cards in the humor section. Okay, and so my cousin, she just turned, this is a true story, she just turned 50, and I got invited to the dinner, and her 3 siblings who so-called love her gave her birthday cards. One of them was about sagging body parts. She thought it was funny, I thought it was offensive. This is the gerontologist, seniors advocate in me. The other one were about her bodily functions not working the same way they used to work. And another one was, I think, about her memory and some other things, and she's 50. So I can't imagine what they're gonna do when she turns 80. So you think about, so that's for me, that's ageism. That, by the way, that store, they did ask us to do a spot in the media, which we declined because it really wasn't one of our big systemic issues that we're looking at. But you know what I would have said if I had been interviewed, because I would have mentioned that at the end, saying how grateful I was that people weren't buying those cards. And by the way, when you go to that store, ask to see the manager and ask them about the card if they would give that to their mother. And maybe they shouldn't be selling those cards. So I did say that it was, you know, a big deal that they were closed because people couldn't get their medications, they couldn't. And some of us, we have a relationship with our pharmacists, especially if you're dependent on certain medications. Maybe you get your vaccination there that day. Maybe you wanted to see somebody that you know, get out of your house because you're lonely. You can buy it's like a general store, right? They sell everything there. But there's one thing I looked at before the interview, which didn't happen, unfortunately, or maybe fortunately. But if you go on their website or any of those stores and type in 2 words, which is really one word with a hyphen in the middle, anti-aging. Okay, remember this backup. Remember the Human Rights Code. Remember, like all those different groups of people that are protected. Seniors are in there too. But so type in anti-blank and see if any of those products come up. But there's an anti-aging section. So you know guess how many products that store carries?
1,000.
Oh, yeah. So you got the idea. It's 260. 260.
I tend to exaggerate.
So you know this longitudinal study that Andrew's working on. I'll tell you about my own longitudinal study in a second that I've been doing. But so there's 260 products that you can lie to yourself about your age, which we'll talk about. So thank you. So there's 3, because that's who you're lying to, really. Everyone else knows your age, I think. So there's 3 kinds of ageism. One is it would be like happened to Gloria. It would be institutional ageism, where the actual systems that we have around us, which our office would look at, and we will look at. So for example, we're going to look at just like Ruth Bader Ginsburg did it for sexism in the states federally, we're going to look provincially, and I hope the whole country does this. We're going to look at legislation, regulations, and any policies that are by nature ageist. And we're going to try to root them out and expose them and say, here's things that we think should be changed. Some of them might cost money, so they'll be harder to change, but we think some of those things are wrong. One example that Isabel pointed out, I will never drop this until we fix it, is it probably applies here too. If you or any publicly funded organization in BC, I'm going to assume is this way, because it was the way when I worked in healthcare. If you want to work past 65, which you're able to do, you're legally able to do, you lose benefits. So one benefit I know I would have lost my last job was I would have lost disability.
Yeah.
So if you get injured, not on the job, I get injured just for whatever reason, you can't do your job anymore, you don't get paid at all. If you're 64, you do get paid. I would say that's age discrimination. Another one is life insurance. Life insurance, if you have it, it goes down. There's other benefits like that that are there. So that's the big one, institutional ageism. Second one is if you're ageist towards somebody else. So if I looked at Andrew and made some judgments about Andrew based on your age and treated you differently, that would be external ageism to somebody else. The one that scares me the most is ageism to yourself, internal ageism. So I'll just suggest to reimagine aging. So one of them might be, if I said, it's Louise.
Yeah.
So if I said to Louise, if I said, you look good for your age, you might say thank you. Okay, that's what my daughters want me to say. They don't want me to tell you the next two things to try this next time someone says it to you. You could say this, if I said to Bev, you look good for your age, I'd like you to say back to me, you look good for your age too. So try that. You can say to somebody, you look good for your age too. See what they say. The next one would be, if you really feel brave and courageous, and you're not sure if you want to be friends with this person any longer, you could say, I could say to Allison, I could say, if you say to me, I look at my age, I might reply back to you and say, how did you think someone who was born in 1969 would look? Right? You look good for somebody who's of your nationality or your background or I never thought that you'd be one of them. So that's one thing. Another one is that you can teach an old dog new tricks. Okay, there's this, so intelligence does not decrease with old age. Memory might, but the thing about memory is what you had for lunch yesterday doesn't really matter, does it? So my theory about memory is, I know there's some experts in here, so I'm sure you know probably the technical way this works, but I think of it as files, like the files in your office, in your brain, and you only have so much room in your brain to remember things. And at some point it's full. And even though most of us try to black out some things that happened to us, those things that you want to forget about that ever happened, you can't do it because it's there. You might be able to kind of put it somewhere deep, but it's still there. And so your brain only has so much space. So at some point, it's there. You're not going to remember anyone else's name. You might try, but that's my idea about memory. So I would suggest that don't worry about things you can't remember from a day ago. If you leave your keys in the right spot, you'll find them. But our daughter didn't leave her keys in the right spot. And she didn't say to me she was having a senior moment when she couldn't find her keys. Senior moment. Because you would think she's 18, so she'll say she's having a junior moment. So one thing is not to demonize those birthdays, not to think of those birthdays and aging as being a bad thing, but to embrace it and to celebrate it. So my example is I'm a runner. So my new age category is turned 55. So my new age category, I'm in the 55 to 59 age category, which I would think would be less competitive than the group I was the past 5 years. But in fact, a year ago at the BMO half marathon at Vancouver, which is the first weekend in May, my group I was in finished slower than the group 10 years older than us. But Walter, who I train with, he's opening up the Sunrise in North Shore. So we have the same things in common. He loves running and he works in this industry. We both finished first. We finished first in our age categories. So I'm only saying that because for me and my friend Walter, a lot of people I run with, the next age category is great. So I can't wait to get to the next age category. So it's a different perspective. So last thing about those products, those anti-aging products, if you're using them, fine, that's okay. So I'm not suggesting you shouldn't want to look good and feel good about yourself. So I'm not suggesting you stop doing that. But I am thinking that if you are proud of the age you are, if you're proud of however you look and how you are, embrace it. It makes it much easier than because you put it on other people. So just think about that. So that's reimagining aging. Future of aging. I mean, we can talk more about ageism, just on this, one other thought about ageism is, so I have a sore knee right now from running, I have a actually knee injury. That medal I got cost me my knee for a little while. And then when I went to my doctor to ask him what was going on, he said, well, Dan, you're getting older. This is what happens. It's wear and tear. And I said, okay, I said, Will, if that's the case, my left knee, it's the same age as my right knee. Why? So this is, we're talking about sort of future of aging. So I don't know if we'll ever have robots. People get excited about robots. It makes the news when you hear about it. Maybe there are some stories that you have as researchers or that you read about, but I still think what is going to keep people healthy and living at home is a person and visiting them and family member and the things I mentioned earlier. So I really think we're going to see the future of, because we're not going to build enough care homes. Regardless of who's in government, the money just isn't there. Unless we start releasing money from ourselves, unless we actually start allowing, and this is really not a Canadian thing to do, but allowing asset testing. Now we do income testing, not asset testing, meaning the value of your home, that might then factor in how much you pay, which would, if you think about it, if you could do a life lease model or essentially own the condo that you're living in, then we could build all these brand new homes. But if we're not going to do that, which I don't think no government's willing to do that. Maybe the seniors advocate can put a report out saying that's an option, and government might want to do it, but it probably won't be re-elected.
You do that, Dan.
Okay. That's advice, don't do it. No wonder Isabel didn't do it the past decade.
Yeah.
So then we're going to end up doing more care. So it's going to be, as I mentioned earlier, wearables, sensors, automated medication dispensers. You'll have respite, you'll have home care and adult day programs, and hopefully other programs like Better Home. Sorry, I didn't mention earlier, Better Home helping. So I think that's that piece there. I showed the lady in the yellowish color, mustard color sweater with the gray hair. She has gray hair. You think about Lisa LaFlamme. So my favorite thing about her is just the story. It's even like worse than it started off with, because so she changed the color of her hair, loses her job. This is the CTV news anchor. The person she replaced on CTV news was Lloyd Robertson, who got to retire when he wanted to. It's also a different gender than her, and he had a full head of gray hair. And then the competition, CBC. But Peter Mansbridge had no hair at all. So there's a double standard there, and so I like the idea of just embracing your age, enjoying how you look. Age-friendly, dementia-friendly. There's a city in Europe, Bruges, in Belgium, which is kind of known as the most dementia-friendly. So all they've done there is their secret is there's an organization called Photon. And if you ask the creator, the founder of Photon, he'll tell you all the physics around Photon, how that relates to dementia and all this stuff. I said, okay, park that for a moment. Tell me exactly what you do. They have support groups for family members. They've educated businesses in Bruges. It's a small kind of medieval style town, and it's easy to get around there. And the stores have a ribbon when you at the front door, and you can see if they're dementia friendly or not. If you go in there, they'll help you no matter who you are and what your abilities are. The day I was there, they happened to have the market in their main square, and I saw a lot of gray hair, and I thought, which of those people have dementia? I had no idea. And then at one moment, all these people started coming towards the main square, mostly in wheelchairs with people wearing yellow vests, and they were I asked who they were. They're from the local nursing home. So one of the indicators I would love to measure in BC is how many times in a year does a senior living in care get outside?
Yeah.
And I don't mean the balcony, I mean outside. That we measure the amount of psychotropics, chemical restraints, and all with their weights and all these things. We should measure those kind of factors too. So they were getting out there, they were in the marketplace, they could buy stuff, they could smell things, and you didn't even notice them. They were part of the community. So I think for me, that's age-friendly, it was barrier-free, and it was dementia-friendly. It was much different than my experience going to the bank and having to get money transferred and having to basically tell the teller, who refused to give me a printed copy of the information I needed. She just refused several times. So finally I said, what if I had dementia and I was computer illiterate? Okay, now we'll help you. But it took me this actually to say that before she would help me. Okay, so path forward, then we want some questions. So you just think about healthy communities, which is really I think if you think of the decade of healthy aging, the WHO, UN decade of healthy aging, that really is the answer to combating ageism, is embracing aging, having age-friendly communities. By the way, I think I mentioned to Gloria already, I saw Alex Kalachi, who started the whole age-friendly movement, saw him this week. I'll tell you about that in a moment where I saw him, but he says hello, and I asked him, what's wrong with age-friendly? Because I know you could critique it. I think Anthony did a little bit of that today. And he did that when he spoke to the advisors for the Seniors Advocate Office. What's the problem with it? The problem, Alex said, is that yes, it is a checklist. That wasn't the issue. I thought that was going to be his issue. His issue is that we're not focusing on the most vulnerable people. And his example, which he can say much more eloquently than I can, is that I think is he in Sao Paulo or Rio? He's in one of the two cities. He says you can, and Vancouver's not much different, because how many blocks away from here are some of the toughest parts of any town, toughest with the mental health and the opioid crisis and homelessness. But it's blocks away from that are the wealthy. So how do we focus our age friendly on that population? He says that's what we need to do. But so this is a big piece, the vaccination piece, having access and programs in senior centers. We're going to map out the senior centers in BC. I know it's already being done, and we want to basically look at how every town could have something that would kind of meet that need. The driver's license, we want to see seniors being able to drive as long as they want to drive and be supported by having that paid for, the medical exam. And certainly we know how impactful it is if you lose your license. And that's why we need better transportation for seniors, especially in rural parts of BC. Seniors, because of transportation issues, are choosing not to get chemotherapy, for example. There was cases where they said that they weren't going to do that because of transportation. They just accepted their fate, or the cost of going into town to get treatment. A couple told me they spent $20,000, which is reality. By the way, the example that was mentioned in estimates, which we'll talk about when we release our first report in a few weeks. Seniors are keeping their cars just in case they need a place to live, and not just. And Allison will tell you all about it. You ask Allison, who is from who spoke today. There's stories about this in the West End, and not just one or two people. And then the last thing is home support. I understand that we're very close to getting this funded, but I know Isabel rolled her eyes just now. But we want to see that being funded. So we'll be recommending that whoever forms the next government puts that in their political platform, and we hope to see that happen. So that's the idea, that if you need home care, you're not paying user fees. So I think we're one of only two places in Canada. Everyone else.
No, we are the most, more than half don't charge anything. Of the, I guess it's 5 or 6 that charge, we charge a lot more. It's the magnitude of what we charge. Some of them have some user fee, Dan, but it's nominal. Ours is not nominal.
And thank you for that. And even if we just do one thing, which is, I think, I don't know how many people there are, but there is some people who are spending more money on home care than what it costs to live in long-term care. So I think it's about $10,000 differential.
The most you pay for a publicly funded bed, regardless of what your income is, because we cap the amount we charge you, it goes up every year. I think it's around $4,000 a month now.
So 36,000 a year.
Yeah, so you can do the math. A lot of people are paying a lot more than 36,000 a year for help coming in the home.
So then if we could simply lower it, at the very least lower it to below that, then it'll be people at home. Some people moving to care because of the cost. Okay, Q&A. Anything I didn't talk about, anything you want to address, or anybody else in the room? There's lots of smart people in this room who know a lot of different stuff.
I'm not the smart person in the room, but what I want to know is about ageism or older adults that either want to volunteer or continue to work. What are we doing to protect older adults that want to work and have to work, because you're talking about the 14% that require work. My generation, unlikely to retire for as long as possible, just purely because of the cost of living and the fact that our children also will be living with us for as long as possible. So that capacity to buffer ourselves is not necessarily there. So what do we do to make sure that ageism actually doesn't influence the way we first access work, and secondly, how much we get paid for it?
Okay, so I wish I had the answer, the clear and simple answer, but one thing I've heard recently is that younger people are thinking that they will not afford a house and can continue working past 65. Not all are gonna have a pension through work, or they'll save through work. So if you think about it, somebody in their 20s right now, and by the way, when you look at age discrimination in the workplace, which is probably the most prominent place it happens, younger people actually experience more age discrimination than older people do. So when you think about that, then how do you create that environment of, when we talk about, it's a buzzword, DEI, diversity, equity, inclusion, and the new one is belonging. So when I was at Kin Village about a year ago, we did application for our second phase of social housing. The belongingness was a big thing, belonging. It's in particular around racism towards First Nations people. So diversity, equity, inclusion, belonging, we have to be including age in there. We talk about other populations, we're missing age, so we have to do that. So I would look at your own policies in the workplace that discriminate against people based on their age, or anybody, and then also creating the environment where it's okay to have an older worker who might even, if I'm allowed to say this, might even fit the stereotype. So there's this perception again that my daughters have, and they may be more computer literate than I am. Okay, so how do we embrace it? And like one great example, I think, is, I know it's fiction, I think, but is a Hollywood portrayal of Robert De Niro and Anne Hathaway in the movie The Intern. If you don't know this, if you haven't seen the movie, the plot is basically, it's like an Orphan Annie story. Anne Hathaway is running this shoe company, kind of based on Zappos, I think. And so she needs an intern. The intern she thinks is gonna be a younger person, shows up as Robert De Niro. Who wouldn't want Robert De Niro at any age being an intern? I wouldn't mind him as an intern. And then he basically saves her, you know what? And a lot of ageist things are in there. Some of the stereotypes, they're more cute than they are offensive, I think, in the movie. They're still there though, but anyway, we need to see more of that, to see people who are older working. In our workplace, we are pretty diverse in terms of age. I don't know how old this worker is, but I think she's in her 70s. Yeah, and she's as effective as, I think, other youngest, one in her 20s or early 30s. So I think you've done a great job hiring a diverse workforce.
One of the stereotypes against older workers is employers there's this issue of inflexibility, but also they're always sick all the time. 35 years ago, when I did my master's thesis, I did a study of sick leave utilization in the support industry. And there was a 70-year-old home support worker, and they worked a full year. There were about 450 observations in the study. This one, not one sick day. And in fact, when you did the analysis and you looked at the correlation between age and sick leave, it was the younger people, for sure, who were taking more frequent sick leave.
And thank you for that. And I'll just add one more quick point. I want to hear other people too on other topics. So there's a typical thing. Earlier today, we're talking about, I think Laura's mentioning the diversity in terms of care homes, right? The ethnic care homes. One of the problems with the ethnic care homes. This happened in Abbotsford when I was working there. It happened, I heard the same thing from other places too. So we at Tabor, we were making the most delicious Mennonite food. So Mennonite food is peasant food. But that's their word to describe it, but it's really basic food. And by the way, the cost is pretty cheap too. But which are our CFO like, but it's borscht, and it's cabbage rolls, and it's pierogies, and it's farmer sausage, it's all that stuff. So then, and a delicious dessert called Bienenstück, which means beasting. It melts in your mouth. It's almost like an inhaler. It's so good. So anyway, so one of the complaints we got was from a couple of lovely women who were basically racist. How can Francisco make this food? I said, okay, here we go. It's starting. I wasn't expecting this, but I heard about it. Might happen. Bam. And these are three well-intended women because they thought you have to be from a certain ethnic origin to cook that kind of food. So, and they even made fun of his accent. So I said, okay, we figured a way of them we did a little bit of sensitization to their training to understand and embrace Francisco and from different cultures. And then eventually they accepted the fact that he could make better food than they were making themselves. That was the big issue. But the same thing you can do with older people. It's possible that you have a 20-year-old and a 70-year-old working together and they can learn from each other, and diversity is good. I would just suggest we need to do this education around diversity of ages.
Can I just add an adjunct to that? Because the thing is we're using AI to select as far as resumes and things are concerned. The ageism is built into the AI as well, because the thing is that is hard. It reflects us and we are ageist. So
the only difference I would say, and it's not always true because a young person, thank you for saying that, but a young person might have a short runway at that company. They probably have a long runway in their work life, hopefully. But I think the only thing that's true, I think, is that an older person does have a shorter runway. Generally, you would think that's the only thing I would ever give the AI. Sorry, you had a question.
I was just gonna add, like, a positive thing is just somebody that I know who's, I think, 68, and is from another country originally and was looking for work recently, landed a job. And during the interview process, the person interviewing said, are you gonna be okay working with younger people? He said, we tried working with a team of the same younger people and it didn't work. And now this person has started, and just the mix. So learning from each other, the experience, the wisdom, whatever the computer stuff is and all that, just if more businesses could embrace that kind of model, really beneficial on all ends of the age spectrum.
Agreed.
Yeah, thank you for sharing your knowledge. My question is the impact of euthanasia in the demographic projections. And the second thing is you mentioned about caregivers who come. Most of them are people of color, and many of them are not even citizens of Canada. So what is their life in terms of whether they can get permanent residence, because many of them are on work permit. And the issue comes that the seniors get so attached to the caregiver, or caregiver gets close, but then after 2 years they have to go. So there is no kind of any security for the caregivers who come from outside Canada.
So maybe I'll talk on that first, please, first, now go into the euthanasia. So I think my own perspective of this is, I know that groups like the BC Care Providers is one example. They're doing a lot of work in pushing forward and making available, you could probably speak to this, around people coming from who are foreign trained and getting credentialed early on. If it's care rates might be easier, but getting citizenship, if they can, are getting landed status. And also you have doctors and other professions. We want to fast track them. So that's a big challenge right now for us. You should be able to absorb them, if you will, because we need them. That's how we're growing our country right now. We're not getting the birth rates, and we're going to need people coming in. So if they're willing to move to Canada, then we should be embracing them and doing everything we can to make them available if they're qualified. So we should be helping them become qualified. So I think we should be embracing that. Want to add to that?
I was going to say that I think another area that is underutilized are families and loved ones who go on a regular basis into a long-term care facility. And I think particularly when we look at the shortages of staff, that if there were opportunities or programs developed whereby, for example, someone could assist in the physical therapy of their loved one and, you know, under the supervision of a professional, with some training and perhaps even the need, which would be fine for signing a liability waiver if you were doing that. I think that's one area. Another area is an assistance in dining, again, with some training, understanding the variations that happen in one's ability to swallow. But when we look at the shortages and in my own life experience, that was you know, an issue in seeing those of us who are designated, you know, having essential care for our loved ones, but could not participate in taking care of some of their needs when, say, physical therapy was not available, you know, during the pandemic, and yet we were there every day. So, you know, when we look at the shortages right now, I keep thinking of the underutilization of people who are willing to participate under some supervision.
And I think that the examples you mentioned, feeding and doing other things like that, I think the same things that you might have done already, you know, the day before they moved in, you were doing that, now they moved in, you can't do that anymore, it's too dangerous, right? So I think it makes sense for that, that's a great add-on to this. The health human resource crisis is gonna get worse. So we have to figure out different things like having people, fast tracking people to be able to be qualified and be able to work, and also other people who could help out. On your question about euthanasia, so I think what you're referring to is medical assist dying. So it is heartbreaking, but it's legal, people can do this. We had a volunteer named Wanda at Kin Village. When I started there, something had happened, I don't know what happened, she came to say she wanted her volunteer job back and got her volunteer job back, and she was basically kind of running our senior center at Kin Village. And then she got diagnosed with lung cancer and decided not to take treatment. And eventually she had pain medication, but eventually she had made, and I'm heartbroken. It was her choice. This is kind of part of the Canadian story now. You can do that. I think where I'm concerned is where people choose that because they are, and again, it's a Canadian choice, but they don't want to go to nursing because they think it has to be a certain way. So I don't find the places I've worked, yes, we can agree them, but they're I'm of the belief of my own personal thought is that that there's an experience there if you choose to do it, and your family may benefit as well, and others might benefit from that kind of, you know, to your example, you might have a loving partner who might want to do this, not by choice, but by a quality of life thing. So it's everyone has different price by the rest of the night talking about this, but I think it's an ethical dilemma. And where we're choosing quality or quantity, and I can't make a judgment for somebody else, but I know it's something that we're pulling with. I'll make sure to make the point properly is that my concern would be that we're not allocating resources because of ageism enough to this, that it's causing people to shorten their lives. I do want to mention the longevity study that I'm doing. So I know, Andrew, how many people are in your study?
53,000 to start, the Canadian Longitudinal Study on Aging.
Okay, so imagine you filled up BC Place Stadium. Let's choose a date, July 5th. It's a Friday, I think. So you know what's happening July 5th at BC Place? You know who's performing?
Rolling Stones.
The Rolling Stones. Okay, so this is my longitudinal study, and they do it on July 5th. And I was really lucky to do it last week too in Seattle with our 18-year-old daughter and her 18-year-old boyfriend. He goes to UW in Seattle, so tag along. We got the cheap seats in the very back of the floor. Cheap seats are so expensive, but they're affordable. It probably bought them one dinner maybe each. But anyway, so Charlie Watts passed away unfortunately. I think he was the oldest of the four of them. Ronnie Woods is in his late 70s. I think he's missing part of a lung. Mick Jagger is 80 and had heart valve replacement therapy through surgery, and who knows what's keeping Keith Richards alive.
We don't want to go there.
Yeah. But I can tell you, so somebody will. This is the ageist language. Still, they still don't use the word still. Okay, Dan, don't say the word still. He's always done it. This is part of the thing is long and healthy life. Keep on doing what you're doing. Mobility is that picture shows. Mobility is a key thing. I was watching Mick Jagger and I thought most of the things he was doing on stage, most of that 53,000 or whatever people in the audience or how many people in the audience couldn't do themselves, could never have done.
Yeah.
We know he's exceptional evening to begin with, but even a fraction of what he did, I couldn't do it, but he was skipping on stage. He was moving around, like, I can only imagine the number of calories he burned in 2 hours. And he hit the high notes. In falsetto, but it's probably always a falsetto. He hit the low notes. He did everything, and he captivated the audience, like, and as did Keith Richards and everybody else. It's 7:34.
Yes. Well, on that note, on behalf of everyone.